Hi everyone, welcome to my YouTube channel Respiratory. Thank you so much. Within 2 weeks, I could get more than 200 subscribers. This is a very good inspiration for me to make more videos which would be helpful to every one of us. Don't forget to hit the bell icon so that you get updates as soon as I post the video. Before getting started, let me tell you one thing. One of my friends asked, why are you making a video on neutrophil extravasation? He said that there are thousands of animation videos which depicted very beautifully. I answered him saying that this one is to a postgraduate level. It goes to the depth of molecular level. It has applied aspects regarding primary immunodeficiency syndromes which are related with neutrophils, and it also has pharmacology aspect which says where anti-neutrophilic drugs act to prevent the tissue damage. So let's get started. Now let's see how a neutrophil comes into the tissues and at what level our anti-neutrophilic drugs act to prevent the collateral damage which is caused to the tissues. Before going any further, I want to ask you a question. How many of you have seen a fighter jet landing on a warship or an aircraft carrier? It just resembles extravasation of blood cells. I feel we humans have imitated basics of chemotaxis to land a fighter jet onto a ship. So this is the process. The jet identifies the ship where it needs to land, and after that it decreases its altitude and prepares for landing. After landing, it travels to certain distance, and then there is a rope on a ship that gets hooked to a rod like thing which is there on the end of the plane. The bonding makes the jet completely to get to a halt. After stopping, there is a person who guides the plane into the parking lot where it is parked in a proper manner. In the similar way, when a neutrophil decides to come into the tissues due to inflammation or infection, the cells of the neutrophil come into the periphery, they start rolling, they form adhesions, and finally they form a tight adhesion. Then there is diapedesis. After diapedesis, the cell which has extravasated moves to the site of action with the help of chemotactic gradient. Now let's have a basic introduction about neutrophils. Neutrophils are granulocytes that are derived from myeloid precursors. Myeloid precursors are obviously divided from pluripotent hemopoietic stem cells. They are synthesized in the bone marrow. Approximately 10 to the power of 11 neutrophils are produced in a day. They have a circulating half-life of approximately 7.5 hours and tissue survival for 1 to 2 days. The number increases by 10 folds in case of any infection. Neutrophils not only play a key role in host defense, they are also responsible for significant damage of the host tissue. It takes 6 to 7 days for a pluripotent stem cell to differentiate into a myelocyte, and almost the same amount of time is needed for a myelocyte to differentiate into neutrophil. Granulocyte colony stimulating factor and granulocyte monocyte colony stimulating factor play a major role for differentiation. Any cytokine that needs amplification of neutrophils needs to act before the stage of myelocyte. Eosinophilic granules start appearing at the stage of promyelocyte. These granules produce many antimicrobial peptides that play a major role in innate immunity. Secondary granules start appearing at the stage of myelocyte. These granules majorly help in destruction of the phagocytosed organism. If the organism is large to be engulfed, there are secretory granules through which enzymes are secreted into the tissues to cause the destruction. The process of neutrophilic chemotaxis starts when bacteria enters into the tissue or by an tissue injury. This results in immediate inflammatory response that involves vasodilation. As soon as there is vasodilation, there is slowing down of blood flow. There is followed by pooling of blood cells. There is also a shift from the cells which are flowing in the center to the periphery. Whenever there is tissue damage or infiltration, the damaged cells and also immune cells produce chemoattractants and also release adhesion molecules on the endothelium. Now let's discuss a little more regarding chemoattractants. Chemoattractants are subclassified into four families. They are N-formulated peptides, complement anaphylatoxins, lipids, and chemokines. N-formulated peptides and complement anaphylatoxins are also called as N-target chemoattractants, which means that when a tissue is filled with lot of chemoattractants, neutrophils will show priority in migration towards the N-target chemoattractants. Lipids and chemokines are called as intermediary chemoattractants. Though both of them have their own signaling pathways, they activate G protein coupled receptors. N-target chemoattractants act through phospholipase 2 and P38 mitogen activated protein kinase pathways. Intermediary chemoattractants would act through ROS and RHO and RAS pathways. Interesting fact is that pertussis toxin can inhibit most of the chemoattractant induced neutrophilic effects by inhibiting the G protein receptors. FMLP is most well known N-formulated peptide. It is secreted by infected bacteria as well. It acts through two different types of receptors. The first one is the commonest receptor, which is G coupled protein receptor, and the other is a specific receptor which is called as FPR receptors. FMLP activates two pathways. The first one is the pathway which we have discussed prior, that is MAP kinase pathway. MAP kinase pathway signals through P38 protein, promotes chemotaxis, TNF mediated ROS release, adhesion and release of specific granules. It also acts through ERK1/2, which causes homotropic aggregation. Salicylates like aspirin act at this point and prevent the aggregation of neutrophils. RAC2 is another pathway. It is a GTPase. It promotes actin polymerization and pseudopod formation. It has been found that in vitro, FMLP causes synthesis of leukotriene B4 from human neutrophils. Both leukotriene B4 and its synthesized enzymes were found to be stored in intracellular vesicles that are released upon activation. This leukotriene B4 pool acts in both autocrine and paracrine fashion. When it acts in autocrine fashion, it causes the movement of neutrophils towards FMLP. In a paracrine fashion, it causes activation and amplification of neutrophils. Complement anaphylatoxin. Complement 5 is the most potent N-target chemoattractant. It usually acts through its own specific receptors on neutrophils and activates PLA and MAP kinase pathways, which would further stimulate the production of leukotriene B4 as discussed before. Lipids are derived from arachidonic acid. They are not usually stored in the granules but are secreted after de novo synthesis upon activation. Leukotriene B4 is most commonest lipid chemoattractant that is synthesized in this manner. Upon activation, there is increased intracellular calcium and reduction in cyclic AMP. Leukotriene B4 plays a major role in neutrophil recruitment both at the early time and also in the amplification stages, as we have already discussed above. PAF or platelet activating factor is another similar lipid chemoattractant that is immediately synthesized. Both leukotriene B4 and PAF are concomitantly synthesized, but PAF alone can induce leukotriene B4 synthesis. PAF causes neutrophilic activation and polarization by acting partly through protein kinase C pathway. Coming to chemokines. Chemokines are nothing but low molecular weight cytokines. They are divided into four subclasses: C, CC, CXC and CX3C. Among all these, CC and CXC are related to neutrophilic activation. Among CC, CCL3 and CCL4 activate CCLR1 receptors on neutrophils and cause their migration. Among CXC, there are 8 different types of CXCLs, which would support neutrophilic activation and migration. They act by acting on CXCR1 and R2 receptors. By this we understood that leukotriene B4 has a major part in the activation and migration of neutrophils. By all these mechanisms, G protein coupled receptors get activated. There is dissociation of G alpha subunit from the G beta gamma complex. This leads to activation of two different pathways. The first one is phosphatidyl inositol 3 kinase pathway. Through this pathway, there is synthesis of phosphatidyl inositol triphosphate, which plays a major role in respiratory burst, adhesion of the neutrophils to the endothelium, and chemotaxis. The second pathway is phospholipase C pathway. By this pathway, there are two other products which are synthesized. The first one is diacylglycerol. It activates protein C kinase. The second one is inositol triphosphate. Inositol triphosphate causes the release of calcium, thereby stimulating generation of ROS and neutrophil movement. Chemokines are positively charged particles and they are immobilized by negatively charged glucosaminoglycans or heparin sulfate, which is present on the lumen endothelial cells. Hence, at the lumen surface, glucosaminoglycans and even chemokine receptors participate in chemokine presentation, which leads to activation of rolling neutrophils. Respiratory burst is a process by which a neutrophil kills the bacteria during phagocytosis. It usually comes at the end stage after the neutrophil comes into the tissues, but I want to discuss it here itself so that it helps in better understanding how drugs act. This is a process by which reactive oxygen species synthesis that would cause damage to the bacteria occurs. So, oxygen is converted to hydrogen peroxide by NADPH oxidase and superoxide dimutase. This hydrogen peroxide is a highly unstable compound. It takes a chlorine atom and turns into bleach that degrades the cell wall of the bacteria. Neutralization is the process that I have highlighted, which is also very important because ongoing ROS synthesis can lead to the cell destruction and also tissue damage by causing robust inflammatory response. Now let's see how drugs act. The exact mechanism by which these drugs exhibit anti-neutrophilic properties is not known. Dapsone is hypothesized to act in three different ways. The most known way is it inhibits the enzyme myeloperoxidase, that is the step where hydrogen peroxide takes a chlorine ion to become bleach. By inhibiting the enzyme, it controls the degree of neutrophil-induced destruction in the lesions. The other mechanism is it may inhibit the synthesis of chemotactic lipids that interfere with leukotriene B4 mediated chemotaxis. The third mechanism is it decreases the adhesion of neutrophils to IgA. Coming to potassium iodide, it acts similarly by inhibiting myeloperoxidase and thereby inhibiting respiratory burst. It significantly inhibits neutrophilic chemotaxis, but how it inhibits is not yet known. Some antibiotics also act as anti-neutrophilic drugs. Tetracyclines are most commonly recognized ones. All the tetracyclines, including minocyclines, reduce neutrophil chemotaxis. Minocycline reduces production of interleukin 8 and thus attenuates the pro-inflammatory process in epidermal keratinocytes. Tetracyclines also chelate calcium, which leads to decrease in the intracellular calcium levels, which is needed for the chemotaxis. Doxycycline is more preferred than minocycline as it has same efficacy with a reduced incidence of adverse effects such as DHS, hyperpigmentation and dizziness. Even macrolides and metronidazole show anti-neutrophilic properties by antioxidant nature. Sulfasalazine, along with its antioxidant nature, acts by neutrophilic apoptosis and enhances adenosine release at the site of inflammation. This makes it special for using it in pyoderma gangrenosum. Thalidomide, it acts by inhibiting TNF-alpha. TNF-alpha usually activates neutrophils through upregulation of complement receptors, that is CR3 and CR4, and endothelial adhesion molecules, ICAMs and E-select. So, inhibition of this step inhibits neutrophilic chemotaxis. Even biologicals and some small molecules have shown antineutrophilic properties. Most commonest ones are TNF alpha inhibitors like infliximab, adalimumab, and etanercept. Coming to interleukin 12 and 23 inhibitors, that is ustekinumab, it acts by blocking Th17 cells which produce interleukin 17 that promotes neutrophilic chemotaxis. Interleukin 6 inhibitor, tocilizumab, acts by inhibiting interleukin 6 which is involved in activation and accumulation of neutrophils into the tissues. Coming to phosphodiesterase 4 inhibitors, which is apremilast, it inhibits the production of TNF alpha, interferon gamma, CXCL6, CXCL10, interleukin 2, 12 and 23, thereby inhibiting the pro-inflammatory cytokines. As the neutrophils move to the periphery and start changing morphologically due to the chemoattractant action, initial adhesion starts taking place where cells starts rolling on the endothelium. This is mediated by weak and temporary bonds. As soon as infection or inflammation is there is synthesis of TNF alpha and histamine by different types of cells that leads to externalization of Weibel pellet bodies which readily express P-selectins. E-selectins are synthesized later by the endothelium. The E-selectins and P-selectins form weak bonds with Cilley-Lewis X proteins. This bonding is responsible for slowing down of neutrophil and rolling over the endothelium. Tight adhesions are formed by integrins. Beta integrins have alpha and beta chains. Alpha chain is called as CD11 and beta chain is called as CD18. This CD11 is again further divided into three subtypes A, B and C. CD11A variant is responsible for formation of LFA1. CD11B variant leads to formation of complement 3 receptor also called as MEC1. ICAM1 and 2 form tight bonds with LFA on neutrophils. Complement 3 receptor mediates activation of inactive complement 3 to its active state and promotes phagocytosis. This may also lead to expression of very late antigen that might aid chemotaxis. Metalloproteinases help in the cleavage of L-selectin which is present on neutrophils. This cleavage leads to superoxide generation, upregulation of TNF alpha, upregulation of interleukin 8 and tyrosine phosphorylation and activation of MAP kinases. Now let's discuss little about applied aspects. The first disease is LAD1, also called as leukocyte adhesion deficiency type 1. This is caused by absence of CD18 chains on integrins. Neutrophils roll normally but are unable to stick to the vessel wall or exit the circulation after chemotactic stimulation. Absence of LFA1 makes neutrophils unable to bind tightly to the endothelium. LAD1 patients have chronic neutrophil leukocytosis. Poor neutrophilic penetration to the site of bacterial invasion leads to necrotic ulcers that lack neutrophils on biopsy. Absence of complement receptor 3 or MAC1 leads to inability to perform complement mediated phagocytosis. Antibody mediated phagocytosis remains intact in these patients. Severe LAD1 patients usually present with delayed umbilical stump separation, umbilical stump infections, persistent leukocytosis, destructive periodontitis with loss of teeth. There are recurrent infections over the skin, upper and lower respiratory tract, GIT, perirectal areas, and septicemia is more common. The most commonest infections are caused with Staph aureus or gram-negative bacilli. Severe LAD patients might need bone marrow transplantation. In a moderate case of LAD1 deficiency, the patients are usually diagnosed later in life and have few life-threatening infections. Leukocytosis, delayed wound healing, and periodontitis are still common. Coming to other disease, which is leukocyte adhesion deficiency type 2 or LAD2. This is caused when Cilley-Lewis X glycoproteins are improperly fucosylated. Gene SLC35C1 codes a GDP fucose transporter. As disease affects the sugar transport, it is now considered as congenital disorder of glycolization. The patients present with neutrophilia and recurrent infections of oral cavity, skin and lungs. This disease might usually improve with age. Most of the patients also have mental retardation, short stature, distinctive faces and Bombay blood group, indicating that this fucolization is critical in many organs. LOD3 is a rare variant and is caused due to mutation of kindlin 3, a molecule responsible for beta 1, beta 2, beta 3 interleukin activation of lymphocytes and platelets. Patients usually present with recurrent infections and prolonged bleeding. Polarization is a state where neutrophil changes its morphology and develops a pseudopod and a tail. In the anterior end or pseudopod, there is actin polymerization pushing it forward, whereas at the backward end, actomycin contractility helps the rare release of adhesions. This helps in movement of the neutrophil through the endothelial cells. Coming to diapedesis, after neutrophil changes its morphology by releasing certain enzymes, the neutrophil passes through the gaps between the endothelial cells and enter into the subendothelial tissue. From there, they move towards the chemotactic gradient, as we have discussed above. After coming into the tissues, they cause the destruction of the organism by phagocytosis. This might be mediated by immunoglobulins or complements.